So hi, welcome today. Another case. And today we're going to go right back to basics. Okay, so a lot of the times when I post these cases, I like to choose the really, really difficult ones, or the ones that are, they've got a lot going on and sometimes they're a poor prognosis. But I have had quite a few of my members suggesting that they just wanted something that's super, super basic. Okay, so this is a case of just a really easy lower left 5 today, okay? And when we kind of assess the radiograph here, we look that it's got a failing composite filling in the distal aspect of this tooth. And then, there's an argument to say maybe there's a little bit of an S-shaped bend in there, but to be honest with you, if I get this type of tooth in a consultation, I know it's going to be nice and easy and not too much bother. What I would say is though, the tooth behind it, the lower left 6, is also one of mine, and it looks absolutely beautiful. So this patient is has been referred to me, maybe I think this is about 2 years ago, for this lower left 6, and it's just nice to see beautiful root canals working well. Okay, another thing about this case is I'm going to use ZenFlex. Okay, so I had the rep out to me a few weeks ago, and she gave me a couple of samples, and ZenFlex is essentially quite a stiff file, great cutting efficiency, and the taper is 0.4. So I'll kind of give you my opinion on ZenFlex maybe at the end of the video here. So like I say, let's get on with the case. So obviously the first thing I'm going to do is I'm going to place the rubber dam, and you'll notice here that I'm actually using multi-tooth isolation. I must admit, there's been a few times on my videos where I have placed a composite filling without a rubber dam, and I've had lots and lots of criticism. So basically what I've done here is I've done a multi-tooth isolation, and what that helps me with is that I can place a composite filling that's got like a sort of that's got a distal aspect that's going to have a contact point with another tooth with the rubber dam in place. And obviously it goes without saying that placing a rubber dam with a composite filling is obviously going to create a better prognosis for the filling, just for moisture control. And then I'm just going to simply remove the temporary filling here, and you'll notice that when we remove this temporary filling, the last dentist who dressed this tooth has dressed it with cotton wool. And I've said it many times before, I tend to use PTFE tape. Cotton wool sometimes can be a bit difficult to remove, especially you put the cotton wool in there, you put the GI on top, and that gets kind of enmeshed into the GI, the cotton wool, and sometimes it can be really, really difficult to remove. The one thing about cotton wool is you can soak it in an intracanal medicament. In this case, it looks like lead mix has been used, and you can't so much do that with PTFE. So use your clinical judgment at the time. I do sometimes use cotton wool every now and again, and then what I like to just use an ultrasonic tip just to clean the cavity out, and sometimes this kind of like vibrates some of the dentin away, or just some of the detritus, and straight away we open it up and we have a look. Massive canal. Again, not worried. This is going to be a nice little case. So despite the fact that there's a huge canal, I look inside this cavity, and it looks like maybe there's a second canal, just because of like the kind of figure 8 shape of the cavity. And basically I want to investigate this. So in the first instance, I'm going to use a fast handpiece, but I think probably a safer way of just investigating a cavity is to use ultrasonic tips. So I'm using these like dedicated endodontic tips, and as I open up the kind of the pulpal roof here, I can see that it is just one very, very large canal. So that's good to confirm that, okay? And because the canal is so large, I'm going to go straight for the working length. I'm using a size 10 here. There's a little bit of a debate between using a size 10 or a 15. Some say 15's better for a more accurate working length check. Me, I think a size 10's adequate enough. If I'm having a discrepancy with the working length, I'm going to use a 15, and then we check the working length here, and it's the 0 reading is 21. So I'm going to use a tooth saver file. This is 1403. This is a glide path file, and I'm going to shape this to 0, okay? These tooth saver file, glide path files are really, really nice because you can kind of bend the tip at the end, okay, and sometimes that's useful. So I'm actually now ready to use a ZenFlex file. So this is a 2004, and I am going to shape this again to 0. I'm going to shape it to 21 millimeters. And like I say, it's got really, really good cutting efficiency. It just really shapes down to length. I don't know if that's because the canal is nice and wide, but it just feels like it's getting to length. And then I'm going to use the next one up. This is a 2504 ZenFlex, and again I'm cutting to 0. And these files look almost like the old-fashioned type of night eye files we used to use. And then we're going to use the 3504. This is going to be my master apical file, and I'm actually going to use this 0.5 millimeters away from the 0 reading. Okay, and again, this 35 ZenFlex file really cuts nicely. So it's at this point we're really motoring along. Okay, so we've obviously opened up the access cavity. Granted, it's already been accessed for us by the referring dentist. We have investigated for an extra canal, and we've shaped, gained the working length, and we've done this really quickly, which is great because this gives us more time for our irrigation protocol. But before that, what I want to do is I want to do our cone fit radiograph. So I just want to make sure that we're getting a GP cone to length adequately, and we're going to use these kind of generic 04 tapered GP points. It's always good to have these kind of different size generic GP points in your sort of armamentarium. And what I also like to do is I always like to check that the end is actually the correct the diameter, because every now and again you get one that's a bit wrong and it can sort of put you off guard. So I use this gutter cutter here just to make sure that it is genuinely cut to 35. And then I am going to measure this. It's going to be at 20.5. Remember, that's 0.5 millimeters away from the 0 reading. And then as I place this GP to length, I am going to just be very gentle, and I'm going to just sort of push it to the working length and then feel for that kind of tug back, so we know that the 35 is fitting snugly at the apical constriction. And we take an x-ray and it looks pretty good, So, maybe there's an argument to say that this might be a bit long, and what I mean by that is usually if your GP cone is right at the radiographic apex, there's an argument to say maybe that you've passed the apical constriction. But we've assessed this, we've done the working length, and we've checked the working length in the GP as it fits into the canal, so I'm relatively happy that this is at the working length. So it's important to mention that off camera, this patient really struggled to get the cone fit radiograph, so she was choking quite significantly. And the X-ray film holder we use is extra big because it needs to sort of take into consideration the rubber dam clamp. So you'll notice here that there's a significant amount of saliva around the tooth. What I've noticed here is that there's no saliva that's ingressed into the tooth itself, but I'm not happy that the rubber dam is got a good seal. So given the fact that the rubber dam is leaked ever so slightly, what I'm going to do is I'm just going to pull out the GP cone, and I am going to put it in my little disinfector. This is a Style Italiano kind of well where you can place a GP cone in, and then I am going to use this Light Cure rubber dam sealer. A lot of people like to use caulking agent. I just like to use this because it just feels like it's a bit less messy, and also we get a bit more control over the setting time. I suppose in a way it's a little bit more expensive, but for me I just prefer it, and we get a nice seal there. And there's an argument to say, do we need to seal it if once we've cleaned it all off? But I think it's really important that you make sure that you're consistent with your sealing your rubber dam. And then, like I say, we've really motored along with this case. We have we've done all the shaping nice and easy. We've done the cone fit radiograph. So what's really important now is that we do our final irrigation protocol, because that is the most important thing about root canal is disinfection. So my irrigation protocol is using sodium hypochlorite. I use 2%. Some people might think that that's quite a low percentage, but in my case, I like to use copious amounts of this activated, and I think it gives that nice kind of balance between disinfection and safety. Okay, I know some people use as high as 6 or even 8%. I am seriously concerned about using such a high concentration of sodium hypochlorite just in case if it leaks out the tooth. I think you'd be in super trouble there. And then I use EDTA activated, and what that does is it kind of removes the smear layer that your rotary instruments have created along the canal walls, and then I activate the EDTA, and then I use a final rinse of sodium hypochlorite. Once I have completed my irrigation protocol, I'm ready to dry off the canal. And although I don't routinely use Wave 1 Gold, I like using their Wave 1 Gold paper points because they are sterile, and I can bend them in a certain way so they're easily accessible. So it creates like a sort of like a little presentation case for the paper points, and they're easily just removed as you're drying the canal. And obviously we're going to place the paper points into the canal space. We're going to pull the paper point out, we're going to inspect the end, and we're going to keep doing that until the paper point becomes dry. That's really important. And then I'm just going to obturate with one fill. Again, you've seen a lot of my videos. I love one fill. It flows into all the kind of lateral anatomy. You make sure you get a really nice seal, and then we're going to just very gently push the cone to length. We're going to cut the excess off with a heater plugger, and then we're going to compact it down with our Mach 2 pluggers. And then when we inspect the post-up radiograph, we've got a really nice result there. So this is just a really simple case. You know, and I always think that, you know, despite it being a simple case, if you do all the steps correctly, you're gonna get a positive result. Okay, you know, a lot of these videos sometimes feel like we're on repeat, but they're just very simple protocols that we've got to adhere to. So essentially, you know, you've just got to open up the access cavity, and you've got to make sure that you're doing it conservatively. You don't want to move too much dentin, but obviously you want to investigate. You want to make sure that you're getting all of the canal anatomy. You're gonna make sure you're shaping as efficiently as possible, because obviously you've got a finite time with the patient. You haven't got all day with the patient, and despite that, anyway, the patient wouldn't sit there all day. And then, as long as you've shaped efficiently and quickly enough, then you've got lots and lots of time then to do your irrigation protocol, which arguably is the most important thing. And that's it. Thanks for watching. Listen, if you like this video, please subscribe to the channel. Please like. If you've got any criticisms about this video, you would have done something different, or you've learned something new, please comment in the section below. And we've got a membership program on YouTube, and obviously if you're a member, you're going to support the channel, but you have early access to content before it's posted every Friday. And also if you're a certain member, you can have personalized videos to questions that are asked on the comment section below. And I'll see you next Friday. Bye bye.